Welcome to PGOG postgraduate class in Obstetrics and Gynecology, and today's topic is a short one, that is menopause and menopause transition. As we all know, definition of menopause is permanent cessation of menstruation because of the loss of ovarian activity, and for that we wait for 12 months for the cessation of menstruation to consider that a woman has entered into the uh, gone beyond menopause and entered into the postmenopausal phase. So absence of menstruation for at least 12 months in that age group is considered as the criteria to label that menopause has taken place. Now this is a relatively new terminology, that is menopause transition. It was defined by Straw. Straw is Stages of Reproductive Aging Workshop. Long form of Straw is Stages of Reproductive Aging Workshop, which was first conducted in 2001 and it was revised again in 2010. So it is a reproductive staging system, or we can say it is a ovarian aging staging system. So either reproductive stages system or ovarian aging staging system. The stages of reproductive aging workshop was first conducted in 2001 and it was updated in 2010. Then it is called as straw plus 10 staging system. So plus 10 is the latest one, which was introduced around 2011. Now, this staging system is applicable for all women, irrespective of ethnicity, BMI, and lifestyle. Exceptions are, it is not applicable to women who have undergone hysterectomy, those who are having PCOS, or those who cancer patients who are taking chemotherapy, those with chronic illnesses such as HIV positive women. Now, according to this straw and straw plus 10 staging system, the reproductive aging can be divided in three phases. First is reproductive phase, second is menopausal transition phase, and third is postmenopausal phase. So this is a comparatively newer terminology, is menopausal transition phase, which lies in between these two, reproductive and postmenopausal phase. Now, this division of phases is based on clinical data. Most important is the menstrual pattern or menstrual history of a woman and associated symptoms. Second criteria is investigative data such as lab investigations such as FSH, anti-Mullerian hormone, AMH, and inhibin. Especially here it is inhibin B, which is more important as compared to inhibin A, and USG based data, which includes antral follicular count. Now coming to this straw plus 10 staging system, as a girl enters after the menarche into the reproductive phase, the first phase is early reproductive phase, that is -5. Then peak reproductive phase is -4 and late reproductive phase is -3. Menopausal transition has early and late menopausal transition phase, that is -2 is early menopausal transition phase and -1 is late menopausal transition phase. Stage 0 is when the final menstrual period takes place. FMP is the short form for final menstrual period and it is considered as stage 0. After the menopause, we have +1, that is early postmenopausal phase, and +2 is late postmenopausal phase. So we can say that broad, these are the 7 subgroups in this straw plus staging system. 3 for the reproductive phase, 2 for the menopausal transition phase, and 2 for the postmenopausal phase. Depending on various clinical presentation and lab results or lab criteria, There are further divisions have been made in these 7 subgroups. Plus 1 is immediately after the menopause, that is early postmenopausal, which is further divided into plus 1A, plus 1B, and plus 1C. Plus 1A is first year after the final menstrual period. So for the first 12 months, it is plus 1A. Plus 1B is the second year after the final menstrual period. And after the 2 years, so after 2 years of final menstrual period, plus 1B ends and plus 1C starts. Plus 1C is remaining for around 3 to 6 years. So total duration of plus 1 is 5 to 8 years, out of which first 2 years are fixed. First year is plus 1A, second year is plus 1B. Now, perimenopause is a commonly used terminology, and according to this reproductive aging system classification or STRA plus 10 staging system, perimenopause includes menopausal transition and first year after the final menstrual period. So it includes -2, -1, and +1A. So if you are asked what is perimenopause, it is a period of which includes menopausal transition, early as well as late, and it includes 1 year after final menstrual period. So it includes +1A. That should be clear. That is perimenopause as far as this staging system is concerned. Now this -1 is the late menopausal transition, after which there is a final menstrual period takes place. Duration of this late menopause transition has been defined by this STRA plus 10 system as 1 to 3 years. So before final menstrual period, 1 to 3 years before final menstrual period is the late menopausal transition phase. Remaining all these other phases have the duration which is variable, which varies from woman to woman, and that is why there is no fixed duration for say -2, -3, -4, or for -5. -3 has again been subdivided as -3A and -3B, mainly because there is a change in FSH value. FSH value starts rising in -3A, whereas it remains normal in -3B. Now there are 3 criteria to divide these phases, and which are clinical criteria, biochemical or lab criteria, and ultrasonography criteria. In clinical criteria, there are 3 features. First is presence of fertility problems or absence of fertility problems, or we can say fecundity, or we can say fertility potential. Second is menstrual irregularity, which is the most important clinical feature which helps us to identify these various phases of reproductive aging. And third is vasomotor symptoms. VMS is vasomotor symptoms. So as expected, early reproductive phase, there are no fertility problems. Peak reproductive phase, few patients might show fertility problem, but late reproductive phase, that is -3, can have fertility problems. In menopausal transition, fertility problems are more prominent, and it is important as more and more girls are opting for late marriages and late childbearing, so that already they might be in -3, late reproductive phase, or even they might be in menopausal transition phase, and that is why it is important to understand that fertility problems initiate right at late reproductive phase, that is -3, whereas -4 only few might have fertility problems. Menstrual irregularity is not there in -5, -4, or -3B, but it can be seen in -3A. -3 is late reproductive phase, where there can be short menstrual cycles, can be the feature of menstrual irregularity, so that there is a more frequent menstrual cycles might be seen. And it is because of the increasing level of the FSH which shortens the follicular phase of the menstrual cycle. So whenever short cycles are there with the aging population of the woman, the short cycles are because of the shortening of follicular phase, whereas luteal phase of the menstrual cycle remains constant. Menstrual irregularity is the hallmark of menopausal transition, which is prominently seen, and it is defined as cycle length difference of more than 7 days in 10 cycles. So this definition is important. When you say there is a menstrual irregularity, as far as menopause transition and this strong staging system goes, you say that there is a menstrual irregularity whenever there is a cycle length variation or differences of more than 7 days in total 10 cycles. In -1 also menstrual irregularity is persistent, but what is seen here is the addition of short period of amenorrhea, where cycles might be lasting for more than the frequency might be, it might be infrequent, with amenorrhea lasting for more than 60 days in this -1 menopausal transition, that is late menopausal transition, which is nearer the final menstrual period. So we can, as you can see here, as a woman passes or a girl passes through the stages of early reproductive phase, peak reproductive phase, and late reproductive phase, towards the end of late reproductive phase, some menstrual irregularity in the form of short cycles is observed, followed by menstrual irregularity with a cycle difference of more than 7 days for a duration of 10 menstrual cycles, followed by menstrual irregularity with more and more periods becoming anovulatory, so that there is a short period of amenorrhea cycles with short period of amenorrhea of greater than 60 days. So that is how it changes, and ultimately then final menstrual period takes place, and then we say that a woman has entered into post-menopausal phase. Menstrual is the most sensitive menopausal transition. Vasomotor symptoms are not seen in the early reproductive or the peak reproductive period. Occasionally, these might be seen in the late reproductive period, but they are more common in menopausal transition. They start in the early menopausal transition, and in late menopausal transition they are very more pronounced, more commonly seen, whereas maximum vasomotor symptoms are observed in majority of the women in 2 years after the menopause or postmenopausal phase, that is +1A +1B, where +1A lasting for first year after the final menstrual period, +1B is the second year till the completion of 2 years after the final menstrual period, and in these 2 years after the menopause, maximum women show change in the presence of symptoms such as presence of vasomotor symptom. Now, after that, there is a stabilization of the hormonal changes, so that +1C vasomotor symptoms decline, and then after around 5 to 8 years after the menopause, then a woman enters into late postmenopausal phase. And in late postmenopausal phase, what is seen is more and more women presenting with increasing urogenital atrophic changes. So urogenital changes and urogenital symptoms are more commonly observed in the +2. +2 is late postmenopausal phase. Now, these clinical criteria are supported by lab criteria and ultrasonographically antral follicular count criteria. So, in the laboratory, we have anti-Mullerian hormone and inhibin B, which are considered together because the changes which are observed are similar for these two hormones. Second group is FSH, most important, follicular stimulating hormone. And third is ultrasonographic criteria, where antral follicular count gives us the idea about the ovarian aging. This reproductive aging is also called as ovarian aging. So as expected, AMH and NEB is normal in early reproductive and peak reproductive phase, that is -5 and -4. Some decline in AMH and NEB is the first feature that a woman has entered into late reproductive phase. So in -3 phase, -3, that is late reproductive phase, there is a reduction or there is a downward trend, declining trend is seen in anti-Mullerian hormone level as well as in inhibin B. Whereas these two hormones, anti-Mullerian hormone and inhibin B, are low or undetectable in menopausal transition phase, that is -2, -1. Early menopausal transition and late menopausal transition, anti-Mullerian hormone will be low or it will be undetectable, and post-menopausally these two hormones remain undetectable. What is happening to FSH? Now FSH is measured in the early follicular phase from day 2 to day 5 of the menstrual cycle. FSH is low in the early reproductive and the peak reproductive phase, that is -5, -4. It is normal in the initial part of late reproductive phase, that is -3B. But it starts rising towards the end of this -3 or towards the end of late reproductive phase, which is called as -3A. So that is why there is a difference between these two, -3B and -3A. That main change is FSH starts rising in -3A. Whereas first hormone which shows decline and shows that a woman has entered into late reproductive phase is the anti-Mullerian hormone and inhibin B. So fall in anti-Mullerian hormone is a definite indicator that late reproductive phase has started. What is happening to FSH initially is it remains normal, but towards the end of late reproductive phase, when it is -3A, it starts rising FSH. FSH is high in the menopausal transition and the value is, it is greater than 25 international units per liter. So any woman who comes with menstrual irregularity, and if you do FSH and if it shows, FSH should be done for all menstruating women in the early follicular phase. That is, you do it on day 2 to day 5 of menstrual cycle. And if it shows value greater than 25 international units per liter, it indicates that woman has entered into a phase of menopausal transition, whereby what we expect is fertility problems will be more as compared to the reproductive phase. FSH is high postmenopausally, it keeps on increasing postmenopausally. Then after 5 to 8 years, when the woman enters into late postmenopause, FSH value remains stable. It is rising in +1, it achieves a stable value, and after many years of menopause, it might show a decline also. What is happening to antral follicular count? These are adequate in the early and peak reproductive phase, where the count is much greater than 8, whereas -3, that is late reproductive phase, antral follicular count starts showing a decline. So along with rising AMH inhibin B, antral follicular count also starts reducing in this phase. FSH initially remains normal, and towards the end of late reproductive phase, it shows a rise. Antral follicular count is few in the menopausal transition phase, occasional in the postmenopausal, early postmenopausal phase, and absent in the late postmenopausal phase. Now, this menopause transition, how you define it? It is a period when there is a menstrual irregularity before menopause. So, menopause transition is a period when it is a link between the reproductive phase and postmenopausal phase in the ovarian aging or reproductive aging staging system. And it is a period identified most sensitive indicator is menstrual irregularity, whereas other findings such as biochemical or antral follicular count are supportive. Most important or hallmark of menopausal transition is presence of menstrual irregularity. We have already seen, follicular phase decides the cycle length. So whenever there is a shortening of the menstrual cycle, as the cycle becomes frequent, what is shortening is the follicular phase. It shortens, especially when the woman enters into the late reproductive phase. Definition of menstrual irregularity in the menopausal transition is cycle length difference of more than 7 days in 10 menstrual cycles. So that a patient might say that some of the cycles I am getting in, say, 25 days. Some cycles are coming after 35 days. So 25 days, 35 days cycle difference is 10. That means she has menstrual irregularity. That is an example. Again, diagrammatically, we can see that what is variable is follicular phase. What remains constant is luteal phase. For all postgraduates, I want you to remember that whenever a woman comes with frequent cycles, what is shortening is follicular phase. With her increasing FSH, there is acceleration of the follicular growth. Graphian follicle develops earlier, and that leads to the earlier ovulation and shortening of the follicular phase of the ovarian cycle. I hope you understand the reasoning behind that. What are the hormonal changes in menopause transition phase? Mainly the change is in inhibin, and out of which it is mainly for the inhibin B. As we know, inhibin B is secreted by follicular cells developing follicles as well as by granulosa cells in the Graafian follicle, inhibin B, whereas inhibin A is secreted mainly by corpus luteal cells, and that is why it is important for us as far as this ovarian aging and follicular development goes. Whenever we say inhibin, we are talking about inhibin B. It has closer relationship with this ovarian aging. Whenever the number of primordial follicles in the ovary is less than 25,000, there is it reflects in drop in inhibin level. So inhibin level drops whenever the follicle count or graph number of primordial follicles is less than 25,000, and when the count is less than 1,000, the ovarian aging is to that extent that a woman enters into the menopause. Fall in inhibin leads to the rise in FSH. Rising FSH leads to the acceleration of the maturation of Graafian follicle and earlier ovulation and shortening of follicular phase and frequent cycles. So these are the mainly hormonal changes seen in menopause transition. This is HPO axis. I want postgraduates to practice drawing all such small diagrams so that it will help further while writing theory paper. Hypothalamus is secreting GnRH, pituitary is secreting FSH and LH, and ovary is secreting inhibin, estradiol, and also progesterone after the ovulation. Inhibin is being secreted by the mainly for developing follicles, and it has a negative feedback on pituitary, and it leads to the fall in FSH normally. Whenever the inhibin level falls, this negative feedback is no more, and that leads to the rise in FSH. So that is how there is an inverse relationship between inhibin and FSH. There is inverse as well as tight relationship between this inhibin and FSH. Meaning is a small change in inhibin is also reflected by an inverse change in FSH. Inhibin B is the sensitive marker of ovarian follicular pool. Estrogen, on the other hand, it shows a rise in menopausal transition. Estrogen level initially shows a rise with a rise in FSH level in menopausal transition. Rising FSH accelerates development of dominant follicle. Fall in estrogen is seen 1 to 2 years before final menstrual period. Now, whenever we give HRT or estrogen replacement therapy, HRT cannot reduce FSH and LH level because FSH and LH level are mainly raised because of the low inhibin. So even if you give estrogen, there is no change in FSH level. That is the reason FSH cannot be used to titrate estrogen replacement therapy is the important concept for the postgraduates to understand that postmenopausally raised FSH level is not going to change even if we give estrogen, because this raised FSH level is because of the low inhibin level in the postmenopausal women. Anti-Mullerian hormone has no negative feedback on pituitary as opposed to inhibin. Anti-Mullerian hormone, which is secreted by granulosa cells, it indicates ovarian reserve. It is a marker of ovarian reserve. It has emerged in last decades as important marker of ovarian reserve, or it indicates indirectly how much is the ovarian function ability present, or how much is the quality, how is the quality of the primordial follicles and developing follicles. Unfortunately, there is a different variability from one lab to other lab in the value of AMH. AMH value changes from lab to lab or from one kit to the other kit, and that is why it is not a reliable, though it should be ideally an important indicator. It is less reliable indicator of ovarian reserve because of this fact, this variability from lab to lab. It cannot predict timing of final menstrual period or menopause. It only shows that there is a fall in ovarian reserve. But when, after how many years a woman will enter into the menopause cannot be predicted simply by doing AMH level. Now, important concept is there a change in FSH and LH value with HRT or ERT? No, because this is dependent on inhibin level, and that is why in spite of giving HRT or estrogen, FSH and LH value will not fall, it will remain high only. There will be no change. Can we monitor ERT with FSH level? Can we decide whether how much estrogen to be given depending on the change in FSH value? Again, answer is no, because FSH level remains same after ERT. It is not dependent on estrogen. It is mainly dependent on inhibin level. Inhibin level remains low in spite of giving HRT or ERT. Thank you so much. It was a short topic, but I hope that so important concepts related to menopause transition, postgraduate students have understood, and how clinically we can use this dropless 10 staging system. Because we know that when the fertility problems can start, we know with this staging system when which is the first hormone which shows a drop. The first hormone which shows a drop is a anti-Mullerian hormone and inhibin. Second hormone which shows a change is follicular stimulating hormone. So these are the important concepts related to this topic. Thank you so much.